Thank you, Hari, for joining today. It's an honor. It's a pleasure to have you.
Thank you for having me.
Healthcare is a 15th year in a row we're doing it. And I think this year has a special sort of standing there. We were talking about how India's healthcare ecosystem can be redefined. And one of the biggest gap in India, we all know, is sort of between the urban and the rural side of the story. I think the disparities between the two sort of is very visible. An uneducated person in a rural area will also know that they don't have an access to the healthcare as an urban area has it, and private sectors are playing a very important role. Government is playing. I just want to understand why this is happening and what are the sort of routes people can close this gap. What should be done according to your experience to sort of close these gaps?
Certainly, no. So let me put some numbers behind
Please.
What you just said, right? If you look at healthcare capacity in terms of beds per thousand, not a perfect measure, but compared across countries, upper middle income countries like China, for example, they have a little more than 3 beds per thousand. Lower middle income countries, Bangladesh, India is one of them, the average is about 2. But these are national level aggregate, right, numbers. But if you really look at state by state data, except for the southern states and western states like Maharashtra, Gujarat, where it is somewhere between 2 and 3 beds per thousand, most of India has less than 1 per thousand. So what you said is indeed true, and the problem is very acute, especially in central India, Uttar Pradesh, Bihar, Madhya Pradesh, Rajasthan, in northeast India. Now, the reason I threw these stats out is the second part of your question was, what should be done to address, right? One of the most, I'd say, difficult activities for a healthcare provider or a hospital company chain is to expand out of the 6 metros because density is lower. The difficulty, though, is in attracting staff to work in those hospitals. Doctors, senior consultants, surgeons, nurses. And the reason they find it difficult is because there's not enough social infrastructure in the tier 2 cities, tier 3 cities in the states that we just mentioned. So when the senior consultants, surgeons, doctors, nurses in the evening, what are they going to do? Where are their kids going to go to school?
Yes.
Right? What are they going to do in the evening for leisure? Where are they going to go for vacations? And as and when this problem is addressed in terms of building out of social infrastructure, you'll find more and more healthcare capacity will trickle down into this. And we're already seeing it happening. Like if you now go to Ahmedabad or Surat or Warangal or Lucknow, Patna, you see a lot of modern healthcare infrastructure taking shape because some of the social infrastructure issues. Everybody thinks affordability is an issue. Actually, it's not. Right, between insured patients and the private insured patients, government insured patients, and wealthy families, there's enough purchasing power in tier 2 cities, tier 3 cities. It's more about being able to attract talent to deliver high quality clinical outcomes in those smaller cities.
Because nobody wants to go to those smaller cities.
I mean, we've been, and so what we've done is right from 2007, we've been backing what we call as hub and spoke networks.
Okay.
Super specialty, single specialty. So, for example, we built out cancer, which is now Healthcare Global, which is one of the biggest in South Asia. We were early backers of Dr. Agarwal Eye Hospital, which is now the biggest in ophthalmology in India. We are now investors in Sharpsight, which is soon going to be the largest in North India in ophthalmology. We did assisted reproduction, we did dermatology. In fact, one of our proudest investments is a network of intensive care hospitals for newborn babies and young children. So outside of the metro cities, if there was a difficult delivery, the odds of that baby survival are close to nil.
Yes.
But now, thanks to Ankura's network in Tirupati, in Khammam, in smaller cities and towns in AP Telangana, these little babies now have a much bigger chance of surviving.
Excellent.
Why are we able to do that? Because now we've figured out a way to attract talent. For example, a neonatal ICU needs intensivists. They're known as neonatologists. There's not many. India is not producing that many neonatologists. So we need to figure out a way to create that capacity before we build out that network. Sorry, long answer to your question, but
See, I think what you thrown the spotlight into not an issue of purchasing power or affordability or expansion plans. I think the spotlight is more about people who are giving quality services. Are they available to do that or not?
Exactly.
You can create but you can't create a mall there, right? You can't create a huge supermarkets there, which these talents are used to, right? They want to be in urban areas.
Which is why we always felt that while India, being very large and heterogeneous, needs different models of healthcare delivery, we've stayed away from funding large general hospital models because not every tier 2 city, tier 3 city can support multiple large general hospitals. So we've always followed the demand supply gaps in tier 2, tier 3 cities for super specialties. So, for example, the logic for cancer to be housed in a 200,000 square feet general hospital is very, very weak. Similarly, ophthalmology. Or, for example, assisted reproduction. Why would anybody want to go to a hospital to increase their chance of having a baby, right? I mean, they would want to do it in a more comfortable setting.
Absolutely.
So wherever there was a weak logic for that super specialty to be embedded in a large general hospital, we felt there was a rationale for a hub and spoke network. And these are less costly to set up, so capital efficiency is high. And you don't need to price the service very high because the footprint is small. And they can be scaled. And we have the expertise in the hubs. So the difficult cases, which are usually only 1 or 2 out of 10, are served or treated in the hubs. And the spokes take care of 8 out of 10 cases which are fairly routine. So we are able to therefore percolate modern healthcare to smaller cities and towns in India at a much lower capex.
Sure. I think that then the question really comes in, there are successful models which are outside India. I mean, mature markets have done this very well. There are enough capacity at the remotest areas as well. I mean, China, you have already given an example at a country level. India is very driven by a private sector. I think public sector is very limited. I mean, probably one name you have multiple aims of, sort of, right? But then public as a policy hasn't played a very important role. So when I'm talking about a private sector play, the development expansion plan, do you think that this will continue as a private sector play, or there has to be a change which has happened? What is the role foresee you in the future you see a private sector playing?
So it's very interesting you asked that, Shalil, because we looked at some data. It's very stark. Over the last 25 years, the government has quietly transitioned from being a provider of healthcare to a payer or a giant insurance company. So if you aggregate central government insurance and state government insurance, now the primary role of the government has become that of an insurance company, right? They're paying for millions of people and they're adding millions of people to the insured every year. So we believe that government has now given up because of the reasons I outlined earlier, right? They're finding it difficult, even if they build hospitals, they're finding it difficult to man them with talented people.
True.
And managing these hospitals is very difficult. And so they've decided to leave it to the market now. Which by market I mean private. Now there is a not-for-profit segment, but again, if you look at the data, empirical evidence shows that not-for-profit healthcare delivery centers can evolve into centers of excellence because the motive there is very focused and they attract the best researchers and the senior, and they're usually in metros where there's a lot of social infrastructure, so they have very, very senior consultants, etc. working there. But they haven't scaled. The only example in India of a scaled not-for-profit healthcare provider is L.V. Prasad Eye Institute. They've done a fantastic job, admirable, right? They should be held up as an example around the world for what is possible. But in all these years, that's the only example. So the conclusion, therefore, is private sector has the ability to push modern healthcare down into tier 2 cities and down into district headquarters just because of the model of being able to get funding, being able to sort of motivate and hire talented people to go and work there and to manage everything so that it's scalable and self-sustaining.
Sure. I think last part, you have emphasized, you have seen hub and spoke model work very well. I have not seen still scale happening. I'm sure there are pros and cons of hub and spoke model as well. What would you say are the pros and what are the cons of the hub and spoke model?
Well, I've already articulated the pros, right? It is more capital efficient, faster to build out the network, brings healthcare closer to point of consumption. So for example, We always say that cost of healthcare is not just the price the hospital charges, right? It's the cost of the family going from a small town to the city, lost wages, boarding, lodging, travel. It's a big burden on a family's annual income, right? So it's very important to push it, therefore, closer to the point of consumption, and that is the biggest pro. In terms of cons, it is obviously, I would say, not every spoke has the latest equipment, cutting edge research, and but there are ways to deal with it. Because, for example, let's take cancer. Because with broadband, etc., what we used to do at HCG is have these tumor board conferences. So if there's a difficult case, the experts in the entire chain would actually discuss that patient's case over a video conference call.
Okay.
And so you had all modalities of cancer treatment present. So you
yeah.
have radiation experts, you would have chemotherapy experts, surgical experts, and they would discuss the case. And then depending on the actions that are recommended, the patient would be shipped to a hub, right? So there are ways to address some of the disadvantages of having a spoke as opposed to being closer to a hub.
Yeah. So I think technology is playing an important role in sort of building that relationship between the hub and the spoke, actually.
Yeah.
Oh, great. I sincerely feel that is going to be the future as well. And specifically like a country like India, it's a geographically a difficult country.
Yes.
It's a culturally difficult country, language-wise a difficult country.
Yes.
I think every complex layered problem, India has it.
Yeah.
But that's also an advantage because we can probably a sort of a community which is very different, at the same time united as well. Thank you very much for the time.
Thank you for having us here, and wishing the summit a
absolutely
big success.
Brilliant. Thank you.
Thank you.